All right, I'm here to talk to you about psychotropic agents, drugs that alter the functioning of the mind. And we are going to talk specifically about antipsychotic agents and anti-anxiety agents, starting with anxiety. So disorders that involve anxiety are among the most common mental disorders. So in terms of drug treatment for mental disorders, anxiety is way up there on the list. Anxiety is characterized by an unpleasant state of tension, apprehension, or uneasiness. Physical symptoms of anxiety are going to look a lot like the same kinds of things you would see in a fight or flight response, because anxiety activates the sympathetic nervous system. So rapid heart rate, that kind of a thing, pounding heart, all of the blood shifting towards glucose availability, etc. But the most profound symptom really is going to be that rapid heart rate in terms of a physical symptom. One of the things that's really tricky about anxiety is that anxiety and depression often coexist, which really poses a pretty unique treatment challenge. So in another video, we're going to talk about depression and drugs to treat depression. So kind of historically, what we used to treat anxiety are the benzodiazepines, which we know a lot about already, which are non-selective CNS depressants, right? So if someone was anxious, remember our continuum chart, if someone was anxious, we would give them a depressant, and that would hopefully bring them to that normal or neutral state. However, if somebody's depressed and anxious, that's confusing, right? Because they're already depressed, so to give them a further depressant will compound their depression. So in the video on antidepressants, I talk specifically about a group of drugs called the selective serotonin reuptake inhibitors, of which Prozac is probably, or fluoxetine is the prototype. And when somebody has this coexisting anxiety depression picture, which is very common, then the drug to try is the selective serotonin reuptake inhibitor. Other drugs used to treat anxiety are benzodiazepines and beta blockers, and antidepressants, which is what the selective serotonin reuptake inhibitor is. And then there's some kind of interesting ones like buspirone, barbiturates, which are like benzos, as we know, but not very safe. And for that reason, giving somebody with anxiety a barbiturate would probably not be a great idea. And then in addition to this is this conversation around insomnia. So anxiety and insomnia are not the same thing, but the drugs that are used to treat insomnia and the drugs that are used to treat anxiety, which are in most cases the benzodiazepines, those drugs do both. So they're central nervous system depressants. They're used to treat insomnia, which we talked a little bit about already when we talked about benzos, and they're also used to treat anxiety. But then if what we're trying to treat specifically is insomnia, then there's some other drugs, and I will get to those at the end of our presentation. So those are other hypnotic, they're non-benzo sedatives essentially, and they are specific for the treatment of insomnia. So we've already talked about benzodiazepines. I just want to refresh our memory because they are used a lot. And you remember that, I'm sure, from the conversation we already had on benzodiazepines. To reduce anxiety with a benzo, you can give the benzo at a pretty low dose. So if someone's having an issue sleeping, insomnia, you have to give them a little bit of a higher dose. So a lower dose is calming, a higher dose would produce hypnosis. The same would be true with the barbiturates, but as we know, the barbiturates are not that safe, and so therefore that would not be where we would want to start. We already know about this thing with benzos. That's this anterograde amnesia. We talked about that, so that's something to be cautious with. Benzos are also anticonvulsants, and they're also muscle relaxants. So you'll see benzos used a lot, but for our purposes in this conversation, we're talking about them for the use of anxiety and also for insomnia. Of course, we cannot forget about the propensity with benzos for psychological and physical dependence and the withdrawal symptoms. So that has to be considered. These are scheduled drugs, as we know. But they are used a lot, which we've already talked about, and they're used a lot for treatment of both anxiety and insomnia. And I just mentioned that in light of this dependence situation, many antidepressants, which are effective also for generalized anxiety, specifically the selective serotonin reuptake inhibitors, and those guys are going to probably be considered first-line therapy, especially if we're worried, if we have any concerns at all about addiction or dependency with our patients. Okay, so I want to talk about this sort of unique drug called buspirone. Buspirone is a non-benzo, but it has a similar efficacy for general anxiety generalized anxiety syndrome, which is what GAS, or oftentimes you'll see generalized anxiety disorder, which is probably what I was probably trying to put there and just has a typo, GAD, generalized anxiety disorder. So buspirone is an interesting drug. It's a non-benzo, and it is pretty effective. But the problem with buspirone, so let me talk about first how it works, is the actions seem to be mediated by serotonin receptors with some affinity for dopamine receptors as well, the dopamine 2 receptors. So this is not a GABA dependent situation. The thing about buspirone, which is unfortunate, is that while it is quite effective for anxiety, it takes a while for it to work. So you see it has a slow onset of action. So the issue with anxiety, especially if someone's having an acute anxiety attack, they aren't going to be super stoked when you tell them, well, this drug will help you, but it's going to take, a couple weeks potentially for it to kick in. So that's not really going to work. It's got this slow onset of action. So for that reason, we don't really consider it effective for short-term use or acute anxiety states. However, it is effective against sort of the general anxiety disorder. So one way to think about this is we might have to do something acutely and then, get them in a benzo for like a rapid onset, and then maybe potentially to get them off of the benzo while the buspirone is gaining some traction. So it's one thing I want you to remember, it's a completely different mechanism of action. So it doesn't have the other things it doesn't do the other things that the benzos do. Like it can't be used as an anticonvulsant. It can't be used as a muscle relaxer. The side effects are not a big deal. The biggest one is headaches, dizziness, nervousness, which is kind of strange for an anti-anxiety agent, right? Because they kind of feel nervous anyway. Nausea and lightheadedness, but it's a fairly low frequency of these side effects. So in the scheme of things, that's not such a big deal. Another thing you don't have to worry about with buspirone is that alcohol issue with the synergistic effect with alcohol and other depressants. So that's not a problem here either. And they're not all that sedating, and dependence is not something we worry about, unlikely. So that's buspirone. It's kind of a neat drug for that reason. So we've already talked about barbiturates. We're not going to really think of barbiturates for anxiety unless we really have to, because of the fact that they are not that safe. You can overdose fairly easily, and that overdose can be fatal. Respiratory depression. They're quite sedating. They have severe withdrawal symptoms. Same with the benzodiazepines. If you're having to use a barbiturate at the hypnotic dose so this would be for sleep, which of course this would work also, but all the things we just talked about in terms of risk. In addition to that, barbiturates cause a hangover, which basically keeps somebody from functioning normally after they wake up. So all of those things make you not super excited about using a barbiturate for either anxiety or insomnia. And now we have some of our others, and it's kind of outside of the scope of our class, but I just wanted to mention some of these other drugs for specifically hypnotics. So for sleep, zolpidem, I can't have such a hard time saying that word. That's Ambien. It's not structurally related to a benzo. It does bind to the benzo receptor subtype, a benzo receptor subtype, which I'm not going to get into. It's type BZ, B as in boy, Z as in zoo. You don't need to remember that. But it doesn't have the anticonvulsive or the muscle relaxing properties. It doesn't seem to be that big of a deal with withdrawal if they stop taking it. It doesn't seem to have tolerance, all of these things we see with benzos. It seems to have, so when sorry, I'm trying to say too many things at once. So when we think about sleep medications, there's a couple. Insomnia is kind of complex, as I'm sure you can imagine. Some people have a hard time going to sleep. Some people have a hard time staying asleep. So those sorts of things have to be considered. This Ambien, zolpidem, has a relatively quick onset of about 30 minutes, and it has a duration of action of about 5 hours, right? So if somebody's like waking up at 3 o'clock in the morning and not able to go back to sleep, this wouldn't be the best drug for them. If somebody's having a hard time sleeping, though, this is okay, right? So it helps them to go to sleep pretty quickly. Zolpidem, Zoliplone is another non-benzo hypnotic, similar to Ambien. The brand name is Sonata. So it's very much comparable to Ambien. Has about a 30-minute onset and about a 3-hour duration of action. So this would be, Sonata is a little bit better for someone really just that has a hard time going to sleep, but once they're asleep, they stay asleep because its duration is not very long. It's the shortest of all of these on our list. And then we have esopiclone, which is Lunesta. This is another non-benzo hypnotic that acts on that same kind of BZ receptor. It's effective for insomnia for up to 6 months. So it has kind of a longer window of how long it actually works, whereas some of those other ones like Ambien, it doesn't seem to work for that long of a time. It has about the same, a little faster onset of action, 20 minutes, and it has a duration of action of about 7 hours. So this one, Lunesta, is good to get people to sleep and stay asleep. And then there's this last one I want to talk about, which is Ramelteone, which acts on or Rozarem is the brand name. This one acts on the serotonin receptors. So there's a couple different serotonin receptors subtypes that these. I'm saying serotonin, I'm meaning to say melatonin receptors. So as I'm sure you know, melatonin is a hormone that's produced by the pineal gland, and it helps to maintain our circadian rhythm. So my experience with melatonin is that it really only works if someone's circadian rhythm is disrupted. So like shift workers or jet lag people, those kinds of situations. So that's how Ramelteone seems to work, is it seems to work just like melatonin would. So it does seem to help people. It's got about a 30-minute onset and a 7-hour duration of action. It has really no evidence of dependence, really no withdrawal. So it's pretty safe long term. It seems to work for a while. Also, if it's going to work, it probably will work for a while. Again, melatonin is it seems to be fairly unique in what it will help. And a lot of cases of insomnia don't have anything to do with this like melatonin disruption. One thing about this particular drug that is good to know is it might increase prolactin levels. So that is something helpful to note. Antihistamines are oftentimes used for sleep. They're sedating. They seem to be best in kind of treating like in situational anxiety, insomnia. There has been in recent time there has been some connection drawn between antihistamines and Alzheimer's and cognitive decline, so that might be something to pay attention to. There's quite a bit of literature on that if that's something you're interested in looking at. So because of that, I'm not a big fan of antihistamines for sleep for a long period of time. They also don't seem to work they don't seem to work indefinitely. And then the older tricyclic antidepressants, I talk about this in the antidepressant lecture, but some of the older tricyclics, one being doxepin, has been used for insomnia, low doses for insomnia. Trazodone is another one that's been used as well. A lot of these older tricyclics have strong antihistamine properties, and so that's why they're effective. If you're wondering why they're effective, that's why they're effective. And it is worth noting that lots of people who have a hard time sleeping one of the things that's oftentimes associated with depression is insomnia. So that's another thing to kind of consider. All right, so those are drugs for anxiety, drugs for insomnia. Most of those we've talked about. Well, we've talked about benzodiazepines, which are probably used most commonly for anxiety and for insomnia both. But these new agents for insomnia have been preferentially prescribed because of the lack of withdrawal symptoms and dependence. All right, really quickly, I want to talk about antipsychotics. Now, this could be a very long conversation, which we're not going to make long at all. I'm going to make it as streamlined as possible. So psychosis is a pretty hard thing to define and or diagnose. Psychosis can look like lots of other things. Or I should say lots of other things can look like psychosis. But kind of in general, this is a pretty severe mental disorder that's characterized by disordered thought processes, blunted or inappropriate emotional responses, bizarre behavior, and that can kind of run the gamut between being underactive, overactive, agitated, aggressive, hostile, combative, or exhibit signs of social withdrawal. Hallucinations are quite common, especially with schizophrenia, which is a type of psychosis, and delusions also are quite common. So when we think of antipsychotic agents, we kind of naturally think about schizophrenia because schizophrenia is treated pretty much exclusively with antipsychotics. And schizophrenia is a type of psychosis. It is not the only type of psychosis. It's just a type of psychosis. Schizophrenia specifically is characterized by delusions, hallucinations, and the hallucinations usually take form of voices that somebody is hearing, as well as thinking and speech disturbances. We don't really know what causes schizophrenia. It's probably a biochemical abnormality, some sort of abnormality, and there's a pretty strong genetic link. It's probably a dysfunction in some dopamine pathway in certain portions of the brain, which we're not going to get into all the different possibilities there, but that's biochemical, genetics and biochemical abnormalities, whether it's a genetically inherited biochemical abnormality or it's just a biochemical abnormality, we don't really know. But there's definitely that link. It's fairly common, affecting about 1% of the population, and usually where it shows up is in the late adolescence and early adult years. So one thing we know about schizophrenia and psychosis in general is that dopamine is a player. And the way we know that is because if somebody takes some kind of a drug, whether it's illicit or otherwise, that increases dopamine, they start to exhibit symptoms of psychosis. So the drugs then are aimed at blocking dopamine and oftentimes serotonin transmission based on this picture that we see when somebody has high levels of dopamine and they present with a kind of an induced psychosis. So treating psychosis, specifically schizophrenia, is difficult, and this is not curative by any stretch of the imagination. The uses of these drugs, I say here, really does pose a very difficult clinical conundrum, and it's the trade-off between alleviating the psychotic symptoms and the risk of a whole bunch of very troubling adverse effects. So there are lots of consequences with these drugs. So that's a part of it. The goal, however, would be to reduce the bizarreness of the behavior. I'm going to circle back around and talk a little bit more about this in a minute. What you do not want to expect with your treatment of psychosis here, specifically schizophrenia, is a cure. This is not curative, right? It's just helping to manage this picture to some degree. So antipsychotics are used, of course, for schizophrenia. They oftentimes are used in the manic phase of the bipolar picture, which we'll talk about later. They can be used, which is kind of like question mark, exclamation point, like what, as an antiemetic, which is an anti-vomiting agent, and for hiccups that cannot be controlled, which seems like kind of like overkill. But of course, this is not forever. It's just for a short term. And the reason why these drugs work for vomiting and hiccups is because in the brain, there's this place called the chemoreceptive trigger zone, which is like all the possible paths to the vomiting center, essentially. And there's dopamine receptors there. And by blocking those dopamine receptors, we block the chemoreceptive trigger zone, which is going to decrease the frequency of vomiting and hiccups. So that's just kind of curious and interesting. But schizophrenia and the manic phase of bipolar disorder is what we're really thinking about here. So I gave you a chart if you want it. You don't need to memorize any of these drugs, but and we're not going to really talk about them in any detail, but you see there's first generation antipsychotics. There's that second one should say, those are the low potency ones. First generation antipsychotics. The high potency ones, second generation antipsychotics, are kind of the newer ones, and some of those might be familiar to you there. Those are probably going to be the newest and the best. So let's just really quickly run through this. So this is all about dopamine blocking. So all of the first generation, most of the second generation drugs are going to block dopamine receptors in both the brain and the periphery. Then we've got some serotonin receptor blockade as well. Most of those second generation, like Zyprexa and Abilify that you just saw, those block, in addition to the dopamine receptors, they're going to also block some serotonin receptors. What we're going to expect to see here is antipsychotic effects. Lots of extrapyramidal effects, and this has to do with kind of the peripheral effects. So extrapyramidal effects are going to look a lot like Parkinson's disease. So how Parkinson's disease presents, all the motor abnormalities, that's what extrapyramidal effects are. It seems to be, so the reason for that is, if you recall from our Parkinson's conversation, people with Parkinson's disease are not producing as much dopamine, as specifically in the basal ganglia and the substantia nigra. So then we see the symptoms of this dopamine deficit looking like, the pill rolling tremor, the difficulty getting moving, all that stuff, gait abnormalities, imbalance, etc. That those extrapyramidal effects seem to be lessened, not absent, but lessened with the second generation drugs. Antiemetic effects, which we just talked about. So the adverse effects, which is they're going to be present with all of them. Extrapyramidal effects very definitely with the first generation drugs, and lesser with the second generation, but still there. Tardive dyskinesia. Tardive dyskinesia refers to a kind of a specific type of movement abnormality that we see with long-term treatment with antipsychotics. It's a motor disorder. We see a lot of involuntary motion. They kind of do weird stuff with their jaw, move their jaw around. They call it a fly catching motion of the tongue, meaning they're kind of like sticking their tongue out like they're catching a fly. that unfortunately in lots of people, once tardive dyskinesia shows up, it doesn't go away even after you stop taking the drug. So that's a real bummer. Urinary retention is quite common. Weight gain, very common with all of them, including the second generation. Actually, in some cases, the second generations, we see more weight gain. Seizure, sedation, really common. I'm going to cycle back down to that in a minute. Postural hypotension, low blood pressure upon changes in position, sexual dysfunction, arrhythmia, sudden cardiac death, dry mouth, big time endocrine abnormalities. So I'd say the big issues here are the weight gain, the sedation. Sedation is a big problem. So you got to kind of like think back. Why are we talking about this? We're talking about this with our psychotic individuals, most oftentimes schizophrenics. People with schizophrenia, this is complex because part of their delusions are a lot of paranoia. And in many cases, they don't really feel like there's anything wrong with them, right? It's everybody else's problem. And so when you give an antipsychotic, they are really sedated, which means that there's really big changes in their personality, and they don't like that, right? That doesn't make them feel good. And so compliance is a really big problem. So they'll start taking them, then they'll see these changes in their personality, or they're just flat, right? Apathy, indifference, lots of fatigue. That's a big issue. So then they'll stop taking the drug, and then they'll get this rebound, and then oftentimes they'll be hospitalized, and they'll be put back on the meds, and they'll be released, and then it's challenging. So these drugs are hard. This is a very difficult condition to treat for those reasons. Oops. And I guess that's all I really want to say about that. So actually one more thing I do want to say about that. So, in terms of like, who do you treat? So, how this kind of, how you make your selection is really what we're trying to do is we're trying really to decrease these psychotic episodes, make it so they're not having so many psychotic episodes. And I think the rule of thumb is if a person has 2 or more psychotic episodes and they're been diagnosed as schizophrenic, then they should be put on therapy for at least 5 years. Some people say indefinitely. And you don't want to play around with that until that 5-year window has terminated, at which point you might be able to decrease the drug, you might not. When person is on and off the drug, it seems like time in hospitals is quite frequent, and it's really hard to get control of that. So with each of those types of drugs, first generation and second generation, you sort of look at them individually, which again, we're not going into it, but so you sort of have to weigh the adverse effects against the potential benefit and what's going on in that patient. But I just want to emphasize that those adverse effects that we discussed are pretty prevalent in all of them. There's really not any that don't have those very severe adverse effects, which sedation being the big one and very common, and then all of the endocrine abnormalities, weight gain, and movement abnormalities and all that. So it's a tricky situation. That being said, I'm going to end our conversation on anti-anxiety and insomnia and antipsychosis, and I will see you back for the next section later.